right. Testing 1, 2. Okay. From cervical spine imaging, the last section, lecture series 5, was basically over the overview of the cervical spine and the acronym that we use so that we don't forget to look for things other than disc herniation, vertebral compression fractures, and so forth. The cervical spine pain, each of those represents a finding that we should think about. Cervical disc disease, obviously, that's what we're kind of looking at. When you think about extraspinal abnormalities, thyroid cancers in the field of view, things like that, muscle tears outside the field of view of the central canal, extremity-associated symptoms. A left tennis elbow is usually a left C5-6 disc herniation, compressing on the C6 exiting nerve root that therefore creates tetany on the common extensor tendon and tears the insertion at the elbow. So extremity-associated symptoms. Most important are in red here on our acronym, and that represents either fixed rigid segments, which are actually more painful and unstable, the instability findings that we see with kinematics. The problem with most imaging studies, supine MRIs and CTs and so forth, patients laying still, not weight bearing, not moving. So we're going to miss a lot of the important stuff. And the rigidity and instability are very important. We'll talk about vertebral anomalies, carry zero, arthritis, ligaments are so important. How selenium is associated with tight ligaments in a noisy arthritic joint. How you can have motor weakness and numbness, paralysis and paresis after particularly whiplash injury, and you may have a normal looking spine imaging study and all the sequelae of injury, and then the non-specific neck pain, which we hear so much about that I'm only including it in our discussion here because you see it in the literature. There are no such thing as non-specific findings. And then spurring, enthesiopathy, and so forth, postoperative changes, artery inflammation, and neoplasia. Here you go. Mostly we learned there were 3 curvatures in the spinal axis, the lordotic curves in the cervical and lumbar area, and the kyphotic curves in the thoracic area. Well, now we go, okay, you know what? There's a sacrococcygeal kyphotic curvature here. Well, okay, so now there are 4 curves instead of 3s. Well, actually, there's 5 instead of 4. The other kyphotic curve happens at the craniocervical junction, extremely important. So you've actually got 3 kyphotic curves, craniocervical junction, dorsal spine at the thoracic area, and then the sacrococcygeal kyphosis, and 2 lumbar cervical curves, the cervical and lumbar curvatures. So functional anatomy, the spine's got 7 small vertebrae. Remember, C1 only weighs 2 ounces, and it's holding up a 12-pound bowling ball, namely your head. So it's amazing how this works. You only have 5 discs, and so you really have 8 segments if you include the skull base at C0, and then C1 through C7 vertebra. You got 8 segments, and you only got 5 discs. So the top 3 segments, C0, C1, and 2, are held together by ligaments. So the suspension of those ligaments is key to craniocervical function and then this disorder. And we got to be able to image those. And that's what we're talking about with this lecture series. Yeah, the facet joints, obviously, the spinal cord in the cervical region is very thick. Remember, the spinal cord is very thick, where there's a cervical plexus comes off for the upper extremities, and down lower in the lumbar plexus where the nerves come off for the lower legs. And it's fairly thin and uniformly in caliber in the thoracic area. And that's normal. And then we'll talk about the vascular elements, the arterial supply of the cord, the venous encephalic outflow of the head and neck, which is basically absent valves, and allows fluid to flow up and down, which is why we need a gravity, which is why our folks on the space station don't do so well in microgravity. 32 muscles and I don't know how many pairs of ligaments and so forth. We'll talk about, again, posterior and anterior ring of C1, the odontoid from C2. This is C1 doesn't have a body, okay? C2 has got this odontoid process. It probably teleologically stoled the body of C1 to form the odontoid process, the thumb-like upward protuberance. Again, this is the most active joint in the human body. Here's one of the largest spinous processes, but the longest is C7. And you'll look at the lateral canals here. So you see the axis is C2 and the atlas C1, and then C3 through 7. And you'll have the posterior tubercles, the nerves exit here. Of course, the vertebral arteries going up through the foramen transverse area. We'll talk about how that transitions in just a little bit. So also think about the connective tissue here. Look at the dense connective tissue along the nuchal ligament and the interspinous soft tissues, and also capsular ligaments. And then the disc themselves, the outermost annulus is very fibrous. Then here's, for instance, the anterior longitudinal ligament, very dense fiber structure. And you can see here where the nerves sneak out at each of the levels. Again, the fibrous component of the craniocervical junction, and you have internal, so-called internal fiber structures and externals. And we'll talk about how all this anatomy works together. But you can see that there is no disc until you get to C2-3. So C0, C1, and C2 are all held together by this beautiful suspension of ligaments, which is beautiful until it gets disrupted or torn. And then here we'll see the anatomy, how the vertebral artery sneaks up the foramen transverse area. So here's the V1 segment until it gets to C6. Remember, it skips C7 in general. Now, this can enter at any level. I've seen it go into C4. I'm not sure what that anomaly means. But generally, from the subclavian artery on that side, the vertebral V1 segment, then the V2 segment is from the transverse process of C6 to the transverse process of C2. And then the V3 segment goes through C1 and around, and then when it pierces the door, it becomes the V4 segment. And it goes in to join its partner from the other side to form the basilar artery. Now the spinal cord itself, arterial supply, we can see that radiculomedullary supply, and the sacral arterial system. And so when we're doing injections around the spine, we got to be careful because we don't want to inject steroids or things that can be particulate because they act like emboli. You can infarct the cord that way. So when we're doing cell injections and regenerative injections, we're getting away from steroid injections. Again, just an anatomic model that we use for teaching purposes. You can see the base of the skull, how vertebral artery goes up. You see the vertebral at the cervical nerves as they come off. Remember, the cervical nerves are named. C1 comes over the C1 vertebral body, and C2, the nerve comes over the C2 pedicle, C3, C4, and so forth. CH, the tricky one, it goes over the top of T1, and then we got to start naming our nerves according to the vertebral body under which it goes. L3 goes under the pedicle of L3 goes under the pedicle of L3, and L4 goes under the pedicle of L4, and so on. So again, the disc, here the nucleus pulposus lives in here. It's very soft like toothpaste, chondroitin sulfate. It has outermost annuli, these concentric circles of collagen that are at 45-degree angles to one another, makes it sort of like a Chinese handcuff arrangement. And the more twist and rotation that you do, the tighter this actually becomes. And here's your spinal cord, and you can see the motor portion here, the lower part comes out, the motor nerve sneaks down that way, and then the sensory nerve comes up, and here's the dorsal columns back here where the sensory information travels. I show this slide just to show there's a lot of anatomy here. If you want to freeze it and go through, it's pretty simple. The frontal, parietal, occipital, temporal, zygomatic, mandibular, maxilla, nasal bones, all those. But this styloid process is important because this can calcify, but it certainly has a styloid-hyoid ligament. And that, when that's a very dense structure, the internal carotid artery can thump on that and create a plaque. And then it can also create trouble where the styloid process is large. It can actually push into the esophagus or the pharynx and create dysphagia, so-called eagle syndrome. And then here's your thoracic inlet. We'll talk after a while about how the nerves and the subclavian artery travel through here, and then the vein goes anteriorly through under the clavicle and between the first rib and clavicle. Okay, just basically talks about soft tissues. You might not think about it until you think about it. Here's your voice box, and Here's the hypopharynx and the oropharynx right here, the tongue. It's the largest muscle, skeletal muscle in the body. In fact, there's a lot of conjecture that the kids' mouths are too small now because they don't breastfeed. And when they would breastfeed, that would allow their tongue and hard and soft palate to develop a better oral pharynx than when they don't breastfeed. Now let's talk about the soft tissues here. Right in front of C1, it can be about 1 centimeter. Now in kids, it can be a lot more because they have very thick soft tissues, and they're very elastic around C1, 2, and that's normal for them. And you get a lot of translation and sliding that it's not an abnormal finding in those kids, but normally like in adults at any rate. After the growth plates close, you get about 1 centimeter thickness here before you get to the nasopharynx. Any thicker than that, you need to start thinking about, and you can have thick tonsils too, by the way, but tonsil abscesses and hematomas after trauma, you got to think about that when you see thickening here, that nasopharyngeal space anterior to the anterior ring of C1. Then you get a little lower to now the retropharyngeal space here can be from about 5 to 7 millimeters. And this is where you can pick up some occult bleeding down through here. Now, it'll push this soft tissue out. And remember, soft tissue is gray because it's water density on X-ray. And the supraglottic airway is black because it's mostly air. That's thickened. You got to explain why. Now, you get down here, the thickening here, the retrotracheal space, that's the esophagus. See, the esophagus runs through here. So, and the cricopharyngeus is one of the sphincters in the esophagus. So dysphagia, you get bone spurs here. We'll talk about it under the enthesopathy section. Bone spurs here can interrupt esophageal motility, and you can get dysphagia from that. But normally it can be anywhere from 2 to 3 centimeters, and that's not abnormal. Posteriorly, the deep muscles, upper back, we talk about the inion, where the nuchal ligament lives, and it goes and inserts the collagen all along the spinous processes, all the way down to the sacrum. And then we start to look at the splenius capitis. We'll talk, the rectus capitis posterior minor is going to be important. We'll talk about that later. That was the first muscle that was described finally in Gray's Anatomy to represent the first place where the musculoskeletal system has a direct connection to the central nervous system. The rectus capitis minor posterior inserts on the dura right back there. So it allows the dura to be modulated when your head flexes and extends. And when hyperflexion, extension injury, motor vehicle collision, and so forth, you can tear the muscle. And the maldural bridge disruption is a big troublemaker. And this is where we're now treating a lot of craniocervical junction problems. We'll go through a needle and inject some cell therapy, stem cells or exosomes, mesenchymal stem cells, bone marrow type stem cells. But whatever we're going to put cellularly to try to fix this muscle, like you'd fix a torn muscle, but you can actually pass the needle. You need to do this carefully, obviously, because you don't want to pith the cord. And you can put it into the thecal sac and actually put these stem cells into the CSF, and that really helps bathe the brain and so forth. And we'll talk more in a bit about how all that works. Again, normal anatomy, radiographically, you can freeze that and go through all this stuff. The AP view, you need to be aware that the height of the vertebral body should be fairly equal, and the height of each disc space should be fairly equal. Spinous processes should be midline, and you notice they're bifid often, and that creates a V here and allows the nuchal ligament to slide in there when you're looking up at the ceiling. Hyperextension, the nuchal ligament has a place to go in this little notch created by this bifid spinous process. And then you see the lateral margins there as well. So here's a nice drawing, and Ron Tribble is our medical illustrationist. He's so awesome. And he takes the Netter drawings and puts them in 3 dimensions. And I think it's very important. And Netter wasn't as aware, I don't think, of the anatomy here, because it really started to gin in about the late 1990s and early turn of the century. Here's a X-ray, the C-spine, normal cervical lordosis. Here's an MRI, T1 weighted. Notice it's fab weighted, nice normal cervix. A cervical cord and upper thoracic. And notice how the tonsils are well out of the way, the foramen magnum, nice and normal. Here's another radiograph here, normal cervical curve, T1 weighted, and then T2 weighted here. Now here's a patient with straightening of the spinal axis, and basically you're able to see the marrow signal, little Chiari 0, kind of low-lying tonsils, not bad, water weighted here, and then fat suppressed here. And again, we talked about the things we want to, you'll see occult stress-related edema and bleeding on this fat suppressed image. Even although T1 is fat weighted, you see fat really well here. On T2, you'll still see fat. It's not completely gone. On this fat suppressed, like a stir image, inverse and recovery image, it's completely gone. So anything bright on these images is fluid. CSF, obviously, and then also here's the vascular structure. And this is the encephalic venous outflow tracts. Remember, this valvelus that allows blood flow out of the head. Again, here's just some nice normal large field of view showing all the disc and vertebral bodies and so forth, and T1 and T2 weighted. This is mostly a T2 weighted, just showing the basilar artery here, the cerebrospinal fluid. Here's the cord. Patient's a little out of, a little scoliotic, so you missed this part of the medulla oblongata and upper cervical spinal cord, but you see the posterior arch of C1 and so forth. And again, you can freeze these images to go through this information, ligament of flavo. Now, here's the kind of the pop test we'll sometimes give when we're doing depositions, because these so-called experts come in, they're going to talk about these MRIs that are normal, and they're missing complete tears of large and very important ligament structures. And again, not to talk pejoratively about anyone. You don't make your candle any brighter by blowing out your fellow competitor's candle. But this is what we do, and we know what normal anatomy is, and folks that don't are going to look at this image all day long and never see this anatomy. But you can also stop here and you can look through the posterior atlanto-occipital membrane, the anterior atlanto-occipital membrane, the apical ligament here, the anterior atlanto-occipital membrane, anterior atlanto-axial membrane, anterior longitudinal ligament. By the way, the posterior longitudinal ligament goes all the way to the sacrum, but it comes right here at about the cleft of the base of C2, the odontoid. From here north is called the tectoral membrane. Same structure. Just for some reason we decided, and when you call it a membrane, it sounds like, oh, well, it's just a membrane. That's probably not a good term for that. It's a very important structure to prevent anterior translation of C0 with flexion. Extremely, you cut that in a cadaver and your head slides off. I mean, that's very important for flexion restraint. All right, again, axial images, the longest coli, carotid artery, jugular veins, sternocleidomastoid, you see your vertebral artery and your trachea, just to get you oriented to what you're looking at. Again, the lateral canals in the C-spine, see how they go anterolateral and not just true lateral. So if you can look down the tube, you got to orient your slice this way and not just do a parasagittal slice. You'll miss that. So it has unique anatomy. We talked about that. Here's how it starts in embryologically. Basically, that little cleft we were talking about is still there at birth, and your ossification centers of your odontoid are still unfused. There's synchondrosis, but usually about 3 years of age, that's either completely ossified or you got a little baby cleft. And by the time you're an adolescent, you shouldn't start seeing, unless you've got an apophysis or congenital non-fusion, the odontoid should be solid. Again, this is just the anterior margin of the foramen magnum. Here's the occipital condyles that sit right on top of the superior articular facets of the C1 vertebral body. Notice how it doesn't have a body, by the way. It's got a little facet so the odontoid can fit here. And that's actually a synovial joint right here between the odontoid and the facet of the anterior ring of C1. Now, this is important. It's not in all these diagrams. You'll notice how the inferior articular surface of the lateral mass of C1 approximates the superior articular surface of the shoulder of C2. Look at this sagittal view. These are two footballs sitting on top of each other. So C2 is convex. The undersurface C1 is also convex. So these things, you need to have your ligaments, suspensory ligaments in place. Remember, there's no disc between the base of the skull, C1 or C2. The first disc is C2-3. So we're not looking for disc problems at the craniocervical junction. We're looking for ligament instability and malalignment. Now, the fact that you got a biconvex relationship here, these tend to, when they slide and they're in abnormal positions, they tend to want to get more unstable. The C0, C1 relationship is a nice convex concave relationship. So C0, C1 is mostly nodding, doesn't allow much rotational change between C0 and C1. But here, C1, 2 is where 45 or half of your rotation occurs at this level. When you turn your head to the right, 50% of that rotation is going to be at C1, 2. And then the remainder of the change, when you rotate your nose to the right at about 45 degrees, that's where C1, 2 stops. And the rest of it, from all the way from 45 to 90 degrees, looking over your shoulder, it's going to be the facet translation from the C3 through C7 facets. So 45 degrees rotation occurs right at this level. That's what's so important. Again, here's just a nice blown up view. You see the nice convex superior articular facet. That's right where that other football from the undersurface C2 lands. Notice how the lower facet starts to have a normal relationship. Again, here's hyaline cartilage covering these articular surfaces, and you got a capsular joint of the anterior atlantodental interval and also along the posterior margin, and the cruciform ligament forms this capsular joint. It's really interesting how that works. Here's a patient with the basiodental interval, the BDI, is abnormal. Okay, this is 14 millimeters, it should only be about 12. And you can see the ADI, the atlantodental interval anteriorly, is widened. So we got a ligament tear here. Just show you this abnormality, although we're talking about normal cervical spine, just so you get a sense. Again, here's our little friend, the two footballs sitting on top of each other. Now, let's look at this. And what are these little triangular structures? What if we were looking at the knee? That's a meniscus. If that was the femur and that's a tibia, here's the anterior and posterior horns of the meniscus. Let's look at it in a magnified view. So because you got these round surfaces, you've got all this space where this green potential space is. That's where the meniscoid tissue lives. It's not as dense and fibrocartilaginous as the knee. And a lot of these meniscoids that are at every facet joint are fat, but they contain a lot of innervation. Remember, we said fat has more innervation than most other tissues in the body. And so you entrap a meniscoid, you got trouble. Here's a patient with an arthritic facet on the right. So the C1, 2 on the right is arthritic. You can see what's going on there. And then here's slightly more normal on the left with some more hyaline cartilage. Again, from birth, the slopes of the shoulders of C2 can be different. In this particular patient, it's very vertical, and that creates an abnormal stability. You see how the articular surface has changed. So if you look at here on the lateral, this C2 water-weighted image, C0, the occipital condyle at the base of the skull, it's got a big wide gap between that and the superior surface of C1. And then look at the inferior surface of C1, the articular surface from the lateral mass of C1, and how it sits on the shoulders. So you get diastasis and you got capsular effusions on this abnormal development. This is a developmental problem that creates down range trouble with the craniocervical junction. Now, the fact that it was congenital doesn't mean that it's not liable to be injured. These are more liable to be injured, not less, with trauma. So the fact that, oh, that's a pre-existing problem, well, yes, but it made the craniocervical junction less able to resist the vertical load and rotatory stress along the left side here. Now, here's a person turned all the way to the right, so rightward gaze here, and this you can see about 80 degrees rotation is normal. If you can do 90, it's actually a little more than you're probably supposed to. It might mean you have ligament laxity. So you turn to the right. The point here is when the patient turns right, they stretch the V3 segment of the vertebral body over the lateral mass and actually can create ischemia. Notice how the green, the ipsilateral right V3 segment's fine. So what you do when you turn your head to the right, you rotate this way, there's actually slack in that V3 segment, but you stretch and you can occlude the contralateral left V3 segment. This matters if you've got a left vertebral dominant system. You're used to not having much flow on the right side. So when you look to your left and you occlude the right smaller vert, your body it already doesn't miss that. But when you got a big garden hose over here in a left vertebral dominant system, and you turn to the right and you squeeze off your dominant garden hose, you can get some symptoms. And so that's why this is an important slide here, to show that rightward head rotation can compromise the contralateral left vertebral artery. And if you're a left vertebral dominant person, then that can create symptoms. And it's often positional. We can ask them, what were you doing when you noticed the problems? Well, I was getting the cereal out of the top shelf in the kitchen and I woke up on the floor. Well, you need to put the cereal on the left side of the kitchen. I mean, there's not a lot that we can do right now for this vertebral basilar dolichoectasia other than identify for the patient. It's very helpful, the dignity of a proper diagnosis, when you don't know why you're waking up on the floor or you're having these weird dizzy symptoms, and all you got to do is move your TV from the right side of the room to the left side of the room so that your head's not always looking to the right. That is very powerful for those folks. Now again, half the rotation when you turn your head occurs at C1-2, and the other half of the rotation occurs when the sliding of the facets occur from the C2 to C7 levels. And again, when you turn your head leftward and rightward, look how narrow the central canal gets. So if you've got all day long abnormally malrotated C1, you got a narrow canal. You're pinching your cord all day long. But you're certainly doing it when you're turning your head right and left. And when you have ligamentous insufficiency and you have an instability here, then you're really getting cord compression. You can get all kinds of strange symptoms besides just neck pain and headaches, like urinary incontinence and things like that, from just head rotation when your ligaments are insufficient. And this shows atlanoaxial rotatory subluxation. I'm going to let you just go through this yourself. But basically, when the odontoid and the anterior ring of C1 are stable, but C1 rotates too far, that's a type 1. But when the anterior ring of C1 moves away from the odontoid, which should be the axis of rotation, that degree is a type 2. And when it really moves away anteriorly, the anterior ring of C1 from the odontoid, it's type 3. Then when it goes posterior, it's type 4. But anyway, atlanoaxial rotatory subluxations are very common in our line of work, particularly after delivery. And we need to get these lined up as soon as possible. Persons don't need to go through very much of life with C1-2 this malaligned. And again, problem is these two footballs sitting on top of each other, this biconvex relationship of C1-2. Now, a lot of doctors, here's a lateral view. Here's the anterior ring of C1, the odontoid, posterior ring of C1. So here's C2. Okay, well, I'm going to stick a needle in here and inject some stuff. Well, what lives there? Whoops, vertebral artery, and about a grillion other things. So people have got to pay attention. I'm an interventional radiologist. We do needle work, but we pay attention to what we're doing. We don't just go in with a fluoroscopy and go, well, those two bones are there, let me stick that needle there. We use MR, we do CT, we do all kinds of cross-sectional imaging, ultrasound, to avoid these neurovascular structures. And again, like we talked about, here's the transverse band of the cruciform ligament on a short axis transverse view. Again, Rob Tribble's masterpieces, these are so beautiful. Remember, there's a bursa, or a capsulosynovial space. That's a capsular joint, just like your index finger, all your fingers capsular joints. Unlike a disc, which is not that type of relationship. So there's an anterior and posterior capsulosynovial joint between C1 and C2. The key for maintaining the relationship of C2 with the anterior ring of C1 is this transverse band of the cruciform ligament. These are the strongest, these transverse fibers are the strongest ligaments in the spine. And when they tear, they don't tear partially. It's an all or none phenomenon. So when you see the little change in signal in these fibers, that's a potentially unstable problem. And what we talk about, C1-2, the most mobile joint in the human body, and it cannot be unstable for very long without creating a bunch of symptoms. Now, sagittal view, remember the posterior longitudinal ligament cruises along, and right about here, it becomes a tectoral membrane, although it's the same structure. We've opened and peeled this part off so you can see beneath it, but the tectoral membrane, the PLL and tectoral membrane coalesce with the periosteum of the clivus, right here where the basion of the occipital bone is. So it just transitions from ligamentous to ligamentocartilage to cartilage osseous to periosteum. It's really cool how that transition occurs. We'll talk after a while about our, and we talked, I think, on a previous lecture about the myodural bridge, the muscle-dural connection. The first place in Grant's Atlas it described a direct connection between the MSK and the CNS and the musculoskeletal system and central nervous system directly connect here, and that allows this posterior lanto-occipital membrane and dura complex not to be pinched when you hyperextend your head and not to be malpositioned or stretched when you're flexing. Now, this little hole in the posterior lanto-occipital membrane is for the what? That's the transition point between the V3 and V4 segments of the right vertebral artery in this diagram. So if you get a torn ligament, you could have an injured vertebral artery on that side. Now, anterior longitudinal ligament here goes all the way in between the axis and the atlas. It's called the atlantoaxial ligament, although it's still the anterior longitudinal ligament. And then between the axis and the occipital the skull base, it's called the atlanto-occipital ligament. And there's your alar ligament, and then your apical ligament there, and then your alar ligament deep to there. And alar is basically a check ligament for head rotation. So when your head over rotates, that's because your alar ligament's torn. So the ligaments allow for the, you've got to it's a cross between a very stable structure, which you need your craniocervical junction and spine to be, to a very mobile function. So it's a trade-off between, it's got to be stable, but yet it's got to be malleable. It's real hard to do, and so that's why this ligament integrity is so important in the alignment of the vertebral body. So the internal ligaments are the tectoral membrane, the cruciate ligaments, the cruciform transverse ligament, and the apical and alar ligaments. The external are everything outside of that. So the anterior and posterior lanto-occipital membranes, anterior and posterior lantoaxial, and the anterior capsular. So let's go back. Internal are the apical, is the apical ligament here, the superior and inferior bands of the cruciform ligament, and there's the transverse bands. Again, internal ligaments, and the alars. So all these structures are considered internal ligaments. The externals are what's external of those. Here's your anterior longitudinal ligament, your posterior longitudinal ligament, and including the tectoral membrane. So let's talk about some abnormal static anatomy. Here's a straightened C-spine radiograph. And again, this is not normal. It's not positional. The spine's not supposed to go this way. And when the spine is straight with loss of curvature, its ability to resist vertical load stress is diminished. So you're more susceptible to injury from a direct overhead trauma. And also, it's elongated. And that's what happens on the space station. The astronauts lose the curvatures, and they're taller because of the length of the spinal column. But when the spinal column's longer, remember the dentate ligaments are attached at each segment, and it'll tug on the spinal cord just like a bell rope, and it pulls the foramen, the cerebellar and vermis and tonsils down into the foramen magnum, creating the Chiari-0 anatomy. So here's a T1 weighted, T2 weighted, and fat suppressed. Now here's some proton density images, and this is loss of curvature here, and again elongation of the spinal column tugs on the spinal cord and pulls the cerebellum down to the foramen magnum. This is actual reversal here, and notice how you see this tear of the tectoral membrane on the proton density image. It's not as well seen on this T1 image because CSF is pretty dark, and on T1 you can't see the contrast between the tectoral membrane and the CSF. So in C1, short TE images, you can't see this stuff as well. On intermediate weighted, look at the CSF's brighter. Now you can see the difference in the ligaments torn. You see a very high grade tear between here and there. simply because we used the proton density versus the T1 series. Here's another proton density that's more normal. So yeah, the tectorial membrane looks normal as well. The curvature certainly is more normal. Now, 5 parallel lines. The head's facing the other way this way, but let's just kind of think in a second. Remember the prevertebral soft tissues we talked about. Anterior to the anterior ring of C1 doesn't need to be more than about 2 to 3 millimeters. Anterior to the ring of C2 can be about 7 millimeters. And then when you get down here about C6, it can be up to 2.5 centimeters, because that's the esophagus lives there. So you got an anterior vertebral line, posterior vertebral line that should be parallel along the posterior cortices of the vertebra. You got a spinolaminar line. So the lamina and spinous process create this arrangement. And then the tips of the spinous processes produce the spinous process line. And again, we go from 4 curvatures. We know now there are actually 5 curvatures in a normally aligned spinal axis. Again, here's a straightened cervical spine with QRA0, and you can see this levoconvexity, this leftward convexity. So when you do this sagittal cut straight down the line, spinal cord will disappear right about here, because the spinal cord is going out of the field of view. You can see the spinal cord getting smaller. It's not really thinner. In fact, look, you can look down the lateral canal, so you know you're not in the center. This is dead center in these vertebrae, and you're moving out toward the right lateral component with that slice. Now remember, most of these images, now Dr. Rosa and I and Dr. Hunt have access to upright MR, so we use those a lot. 90%, 99+% of these MR images are obtained in a recumbent position. Even though these look upright, the patient was laying down. And when you lay down, because of the curvature, the concavity of the occipital bone in the weight, the brain slides back out of the way. So the degree of cerebellar ectopia will be underestimated in a recumbent patient, as opposed to one sitting upright where this slides back down. And now it's a lot easier to see cerebellar ectopia and changes in the curvature of the spine in patients that are sitting or standing upright. Again, abnormal, normal anatomy. Now, what's interesting, it's so counterintuitive. Dr. Dennis Wogan taught me this. And here's a patient here with straightening of the C-spine, and he put a 2-pound weight on her forehead, and then here's a 4-pound weight. And the more weight on the patient's forehead, the greater the return to normal lordotic curvature. In other words, the response to having the weight on your forehead is to recapture the lordosis and get that weight back over the center of your cervical cord. And the cervical spine is in a pretty good spot. It's about 1/3 of the way back, front to back, for holding up the bowling ball. The T-spine is not too good a spot. It's way back posterior, and you got the lungs and heart in front. And then the lumbar spine is almost dead central. So it's in a really good spot to hold up vertical load. But this is interesting. The more pressure on the forehead, the more improved the cervical spine curvature. Kind of counterintuitive. Here's the old flexion, extension, neutral kinematic series. This is not normal, but you're going to miss a lot of information by not being able to see the changes in the translation of the vertebra from complete extension to complete flexion. And that's what we're able to do with fluoroscopic exams. Now here's a static exam here, and the facet joint looks normal. Superior articular facet of C3, and there's the inferior articular facet of C2. Here's C1 and the odontoid. You do flexion and look at the subluxation. So now you got a jumped facet, and this is unilateral in this patient, but it could be bilateral. It's very dangerous. Unilateral facet subluxation happens, and you can see vertebral body translation and also distance in the interspinous interval and translation. So you got to start thinking it's facet dislocation. Then, if it's bilateral, you look at how the anterior translation, C5 and 6, compared to a unilateral facet joint dislocation. And this is can be death sentence, that degree of instability. And we can't miss that in the ER. We can't send those patients out. Here's an avulsion fracture. off the tip of the anterior inferior aspect of C3. And then degenerative change at C5-6. Now here's a CT on a patient that's got instability at the craniocervical junction. Notice how the odontoid's almost into the, up through the foramen magnum. So it's markedly abnormal here. Although the cervical curve is normal, this is neutral. And again, this is a CT, so the patient's laying down. With extension, there's a little bit improvement. The odontoid's less invaginating into the foramen magnum, and with flexion, it's worse. So we don't want to be doing flexion because you're going to pith the cord and also the cerebellum. After traction, a few weeks of traction, it's a little bit better relationship, and eventually the surgeons decided to put in a craniocervical fixation device because of instability. Occasionally surgery is necessary, but this is a severe injury and dislocation of the craniocervical junction. We do not need to be doing surgery on the majority of the patients with craniocervical dysfunction. We need realignment, plus minus regenerative and cellular therapies. This is an attempt at doing a flexion extension view on a recumbent patient. So you can put a pillow under the shoulders and you get kind of a poor man's flexion MRI, and then you put a pillow under their head and you get this hyperflexion, and you do see some instability. This is not the same, however, as sitting a patient up or standing him up where the bowling ball, the 10-pound weight, is on top of the spine. I mean, this is helpful, but it's not really much more helpful than the static spine series. And then kinematic series, this is an upright MR, open MR, and it just shows the neutral view, flexion view, and extension view with the patient upright and weight bearing. We do a kinematic series where there's several series, and I'll have a video for that for you to see, where you can see them throughout flexion and extension, but it's still not as good as the fluoroscopy because those images are taken, it takes several seconds to take each image, and you have the patient move their head and take another image for several seconds, have them move their head. It's not a constant, continuous motion like we get with our fluoroscopy, like digital motion X-ray and vertebral motion analysis systems. And again, when you have malalignment, and this is what upper cervical docs look at all the time, this malalignment creates change in caliber of the spinal column. And this can create compression and deformity of the spinal cord. That's why the patients get strange symptoms. This is the ventral motor portion of the cord here, and there's the dorsal portion. So you might get sensory problems from compression here dorsolaterally, and you might get motor problems down here, including bladder problems and so forth, and dysphagia and gastrointestinal issues just from this malalignment at the craniocervical junction. Again, on a CT with the patient supine, the occipital condyle and superior articular surface of the lateral mass of C1 looks fine. When you sit them up, look at the malalignment. This is ligament laxity here. With traction, this is diminished, but traction is not a natural way. There's nothing really physiologically that pulls your head up each day. So what we have to do is, even though it improves alignment, we have to maintain that alignment, and that's where we start to do injection of cell therapies like stem cells and PRP and things here to improve these capsular ligaments to maintain that alignment once you've realigned it. And again, the malalignment to craniocervical junction, everything south of that is going to be abnormal and affected by that. So people come in with short leg symptom, pelvic tilt, and so forth. It starts right there at the cranial base, the craniocervical junction. And when you get facet issues, you get symptoms, palpable pain and trigger points in these areas. The lesser and greater occipital nerves are part of C2, and here's a third occipital nerve. These are sites for a lot of so-called migraines, and we do injection therapy at these trigger points and endpoints of these nerves. The patient have remarkable, almost instantaneous relief of symptoms. We'll talk about the liftoff technique using buffered D5 or buffered 5% glucose and how markedly improved these persons are. Okay, that will do it for this session. The next session will be about cervical disc disease, and this was lecture 6. Thank you.